Thank you. Good morning. Thank you all for coming today, and thanks to the organizers to giving me the chance of talking about the project of creating a European treatment plan. So the idea started at a Nordic meeting a couple of years ago. We agreed that it would be nice to have a Nordic treatment plan. So the first who took an initiative was Dark from Norway, and then Jonas Axelsson from Sweden was included, and I was also included in the group. And we decided to work together on forming this plan. We decided that it should be, firstly, a plan for general practitioners, and then we would do a follow-up with a plan for specialists. And finally, I don't know how that happened, but we decided that it should be a European plan. So, and this is, of course, work in progress. So this is just the outline of what we are doing. We intend to be finished by the first preliminary plan by the end of the summer. So this is what it's built up of. We have the first part is for diagnosis and probable causes. So we're looking at how do we diagnose ME/CFS. We have included firstly the IOM criteria and also the international consensus criteria. So the idea would be, at least what we have planned in Denmark, is that the general practitioners could use the IOM criteria, and then for a final diagnosis, the patients have to have the diagnosis by the international consensus criteria. Then in the text, we look at probable causes, viral infections, neuroinflammation. We describe what fatigue is, what is exercise intolerance, and what is post-exertional malaise. We have a chapter about quantifying disease impact, so with different questionnaires, and also with different objective measures that we think and have used, at least in my clinic, for a long time, and find that they are very helpful when we are going to treat patients. Then there will be a lot about the different treatments. And just to show you what it would be like, and don't worry about the next slide because it's very busy, but this is like the half to 1 page of information regarding, in this case, fatigue. I talked to some general practitioners and they told me, don't ever write more than 1 page because otherwise we won't read it. So we kept it as short as we could, and then we would leave them with a number of references if they need more information. So the way it's built up, or supposed to be built up, it would be on the internet, and because in that way we can constantly update the information in there. So the idea is that you click on this, so you don't have to read the whole book or find the chapter. Much easier this way. So if you click on that, you would be transferred to the algorithm for the diagnosis according to IOM criteria. So this is directly taken from the publication from 2014 by the IOM. So this is a fairly easy way to do a screening, at least in my mind. We will probably discuss that. But this is one way of doing it. And so you click back, and you can then, if you like, click on the final diagnosis for ME/CFS. And then you would have this that we use in my clinic, that was my clinic, these 14 points. And there will be about 3 or 4 pages on how to quantify, or how to ask or get those points in here, and what points need to be fulfilled in order to give the diagnosis of ME/CFS. So back to the content. You can then click on viral reactivation or infection as a probable cause. and then there will be a description in here. It's much longer than this, but I just focused on a few things because I think it's interesting that during history there have been ME patients at least since 1880s. The Russian flu gave long-term fatigue. They called it post-influenza nervosa. And also in the Spanish flu during the First World War, they were the same. They called it sleeping sickness in Denmark. And here they called it officially post-influenza asthenia. So there is a history of viral infections that have caused long-term consequences, pandemics long before the COVID-19. So we've seen this before. We've also seen smaller episodes of local epidemics in Los Angeles, in Akureyri, and when after this, ME was called the Icelandic disease. ME got its name during the epidemic at the Royal Free Hospital. When it first hit, it was primarily nurses that had the problems. So the doctors thought this was hysteria. And it was only when the doctors began to get the same disease that they realized that this must be a somatic disease. And so they call it benign myalgic encephalomyelitis. And then there have been other incidents of this. So if we go back then, or go further to the antiviral treatment, so the idea is that you read about the probable viral course, and then you read about the antiviral treatment. I have here focused on valacyclovir, which is something that I use a lot, and there's been a lot of studies and a lot of discussion on it. But what we know is it's easily absorbed. It inhibits the replication of DNA in herpes virus. It has been shown to be safe and efficacious, and the safety profile of these drugs are really good, and it's very seldom that you develop resistance. So, and there has been a group in the US who have followed patients for 20 years on chronic valacyclovir treatment without any side effects. So it seems like a pretty safe drug that we can use sort of off-label. But if we know that the patient has a herpes virus infection, then, or reactivation of a herpes virus infection, it's a good idea to use valacyclovir. That at least is what I've used for the past 6-7 years. So back to the probable causes, looking at neuroinflammation. And neuroinflammation, as you know, is a very common feature in ME/CFS. It's been suggested that it is the protein secreted by the Epstein-Barr virus that changes the blood-brain barrier and makes it more accessible to cytokines and inflammatory cells. This is a very early PET scan from Japan from 1999, I think. This is a normal subject, and what you can see, there is a increased activity in the hypothalamus and in the thalamic area. And what they use is what we call a translocator protein that is indirectly measuring or showing inflammation. And this is a patient with ME. And what you can see is there's lots more activity in the hypothalamus and in the thalamus. And that supports the theory that has been put forward by some, that the inflammation seems to start in the hypothalamic area and then spread from there to the rest of the brain. So when it affects the hypothalamic area, which we could see from the study from Holland, where they had these autopsies, that there were almost no cells in the hypothalamus of these patients. So what it does is we explain the widespread pathophysiology because the hypothalamus has the overall control of the adrenal glands and of the autonomic nervous system, and the thalamus is sort of the sensory relay part of the brain. So that would also explain the hypersensitivity that we see in a number of patients, or most patients actually. So the logic next step would be to press on treatment for neuroinflammation, and I've just focused on low-dose naltrexone because there are two important ongoing studies at the moment, one in Canada and one in the US together with Sweden. So the low-dose naltrexone is something that we've used for many years to stop patients from overdosing on morphine and other opioids. It's used in a dose of 50 milligrams in the emergency room, and that really does work. But then about 20 years ago, some researchers found that if you give a very low dose, as it is the case with many of these drugs that works on receptors, that if you use a low dose, you have what we call intrinsic activity. So they would stimulate instead of blocking. And what they used was doses from 0.4 or even less up to 4.5. And it does have an effect. That's the clinical experience. It does have an effect on both pain and inflammatory symptoms. It's almost completely absorbed from the gastrointestinal channel, but the problem with LDN is that the bioavailability is from 5 to 40%. So there's an 8 times difference in how much is taken up, and that's a challenge. So that's why we have to have a schedule to increase the dose over time to find the right dose for the patient. Because if you go directly to 4.5 milligrams, you will have a lot of side effects. So these things are also in there, a schedule on how to increase the treatment. It has a dampening effect on immune cells in the central nervous system, and it also counteracts the pro-inflammatory activation caused by pain. We know that patients have pain, but the pain also stimulates the inflammation of the brain. So we have to cut that somewhere. So that's why LDN seems like a really good drug. Not good from a bioavailability point, but good from, if you do it right, you can get good results without side effects. So a Finnish study by Olli, is probably somewhere here, looked back at 218 patients receiving a dose like this, and they found a positive response and not that many side effects. And there's a placebo-controlled study, like I said, also in Canada going on, so hopefully we'll have the results next year, I guess. So we can use it, and we have an indication for ME/CFS for LDN. So back to the contents, or actually I'm a bit ahead of time, but that leaves more space for questions. So what now? The contents will be finished as a first draft in August and September, somewhere around there. I'm optimistic because now I'm retired, so now I have time to do this. We will find general practitioners and ask them to review it if they can use it in their daily practice, because that's important. Without their approval, it doesn't really work. We will then transform the text and make it available on the internet. We are seeking funding for that. Hopefully we'll get it, because I think it has to be a dynamic treatment plan, because we're constantly getting new information, and hopefully we'll get more and more information on treatments. So we have to interact and follow what happens in treatment of ME constantly and update the internet. And that's the only way we can do it, is by using the internet for that. So with that, I thank you for your attention.